Thank you. Oops. Thank you very much. Thanks for the kind introduction and those great words which I wrote. Apologies. We've had a lot of problems, as you can see. And, you know, it's hot outside. It actually is even hotter inside when you're trying to get your computer to communicate with the projector, which for some reason it's been really reluctant to do. I'm blaming the projector. We've changed the computer. Now we've changed the projector. Let's see. So what I've said is, we don't need a projector. We can talk anyway, okay? Because some people say that I can talk better without a projector. But who knows? You know, miracles can happen. So what I would like to talk to you about tonight is high-risk prostate cancer, what it means, and how we should manage it, and what new changes or new developments there might be in how we manage men with high-risk prostate cancer. So we may or may not have slides, and I apologize if we don't. I probably apologize if we do, because it's taken so long to get the damn things up. Prostate cancer, as you all know, is a huge problem. About 10 to 15% of men who have prostate cancer are diagnosed with what we call high-risk prostate cancer. So this is cancer that still is confined to the prostate. It hasn't spread outside the prostate. So that still gives us the potential for curing the cancer by eradicating the cancer in and around the prostate. But a high-risk prostate cancer is one that has already spread outside the confines of the prostate into some of the fatty tissue around. It's what's called a T3 prostate cancer. Or it could be a cancer where the PSA was high to begin with. And normally we consider it when the PSA is over 20 to begin. And probably the most important factor that predicts and defines a high-risk prostate cancer is what's called the Gleason score. And this is found on biopsy. So when somebody goes to their urologist initially wondering if they've got prostate cancer and have a biopsy of the prostate, the key thing that we want to see on the biopsy is what's called the Gleason score. And this is what the cancer cells look like, if they look like reasonably ordinary or if they look very different and aggressive and look like cancer cells that are kind of on their way outside the prostate. So high-risk prostate cancer is prostate cancer that's still confined to the prostate, but we know is at high risk of escaping and going to other parts of the body sooner rather than later. You know, most of us have heard people say, oh, you know, prostate cancer, you'll die with it rather than from it. That's not always the case with high-risk disease. This is a cancer that's a killer, and this is the prostate cancer that men can die from. So how do we treat it? Surgery, radical prostatectomy, as you know, is often said to be the gold standard. There's a really good paper from Princess Margaret Hospital where they looked at results of radical prostatectomy over a long period of time, over about 15 years, and looked at men who had what we call low-risk disease, which would be Gleason 6 cancer, intermediate, which would be largely Gleason 7, and high risk, which would be Gleason 8, 9, and 10 at diagnosis. So these are large numbers of patients coming from excellent center in Canada, in Toronto. All the top urologists were involved, Dr. Fleschner, Dr. Trachtenberg, Dr. Finelli. These people, I'm sure, are people whom you all know. So how do these men do after radical prostatectomy? Well, at 3 years, for high-risk prostate cancer patients, 1/3 of patients were still without disease. In other words, by 3 years, 2/3 of patients had developed a recurrence after prostatectomy alone. So radical prostatectomy on its own is not a very good treatment for high-risk prostate cancer, given the fact that 2/3 of men will get a recurrence of the cancer within 3 years. So on its own, it's not adequate. For long, radiation treatment has been considered a standard treatment for high-risk prostate cancer. And the advantage of radiation treatment over surgery is that you don't have a margin. You can have whatever margin you like when we're treating prostate cancer with radiation, because the radiation, when it comes certainly from the outside, can treat a margin of normal tissue outside the prostate. So if there's cancer cells that have already penetrated through the covering of the prostate and escaped into some of the fatty tissue around, it's relatively easy to cover that with radiation, with external beam radiation. So there have been big, what are called randomized clinical trials of radiation treatment for men with high-risk prostate cancer. And the results are reasonably good. The biggest randomized trial is a European study by a researcher called Michel Bolla. And what he did is he took men who had high-risk prostate cancer and randomized them to either have radiation treatment on its own or radiation treatment with 3 years of hormones. Okay? So everybody had standard external beam radiation, and half of the men also had 3 years of what's called adjuvant hormone treatment after radiation treatment. How did they do? Well, by 5 years, those who had radiation alone, about 45% of them were free of recurrence. So somewhat similar perhaps to the surgery, the radical prostatectomy story. But those who had hormones for 3 years, 80% of them were free of recurrence at 5 years. So surgery on its own, 33%. Radiation on its own, from the big study, 40-something%. But radiation plus hormones suddenly goes up to 80%. And that's why, when we treat men with high-risk prostate cancer, we say the standard is to give external radiation treatment and some duration of hormone treatment. And that's why a lot of men receive hormone treatment or androgen deprivation therapy afterwards. You would need to command your computer to talk to the new projector. Computer! Talk to the new projector. I don't think it's working. So external beam radiation and hormone treatment, also called androgen deprivation therapy for 3 years, has emerged as the standard option or standard treatment for men with high-risk prostate cancer. And the results are okay, but how can we do better? Well, we can do better in 2 ways. One would be by improving the cure rate, because men after radiation and hormones can still develop recurrence either within the prostate or distantly. So the ways we might tackle that would be to give a bigger dose of radiation into the prostate than we can get with external beam radiation. And the way we do that is to give some of the radiation using what's called brachytherapy, or internal radiation. Another way to improve results might be to tackle distant disease, to help target any microscopic cancer cells that had spread. So we know we don't like the word, but maybe could we add chemotherapy and treat early on with chemotherapy as well as hormones to these men? Because the biggest problem that these men run into when we treat them is a risk of distant metastasis, risk of cancer appearing elsewhere in the body. So maybe if we were to use hormone treatment and chemotherapy and maybe push the dose within the prostate with brachytherapy as well, maybe we would actually improve results. And there have been some clinical trials, which I'd like to tell you about if I can, which have asked that question. Also, maybe we could help reduce side effects, because a big problem that men encounter when they're having treatment for high-risk prostate cancer are the ongoing symptoms from being without testosterone. So one of the biggest problems that men face, and many of you know this, would be the hot flashes, the sweats, the loss of sex drive, the loss of libido, the loss of energy, putting on weight, the feeling that I'm not quite as much a man as I used to be, that comes from being on hormone treatment for 3 years. So maybe we don't need 3 years. Maybe 2 years would be enough. Maybe 12 months. Maybe 6 months. So can we, again, improve results by limiting side effects, but still get really good disease control by limiting the duration of androgen deprivation therapy? So the first strategy, intensify local treatment by using brachytherapy. Now, I love showing photographs and pictures of brachytherapy, as you can see here. Let me try to show you what it's all like. I need a volunteer. So brachytherapy is a way of treating cancers in various parts of the body, not just prostate, because, you know, there are cancers other than prostate cancer, but we use brachytherapy to give radiation by putting the radioactive sources right into the prostate, right into the cancer, wherever it might be. And the advantage of doing such a strange thing is that it gets us a really high dose of radiation into the heart of the cancer, and then very little radiation anywhere else, because the radiation is given off just in a very small area around each of the radioactive seeds. So the radiation dose falls off. So when we're treating prostate cancer, it's a way of giving a big dose of radiation to the prostate, and often just to different parts of the prostate, where sparing the urethra, sparing the rectum and bladder, which can be spared a lot of the radiation dose. Now, brachytherapy has been around for a long time. The first reported case of using brachytherapy to treat prostate cancer wasn't in 1980 or 1960 or 1950. It was 1909. So people have actually been treating prostate cancer with brachytherapy for over 100 years. The biggest, you know, initially it was done a little bit differently in 1909. What was done at the time was radium needles would be inserted into the prostate and left for a certain length of time. But, you know, technology evolved, and a lot of this was actually driven in New York, in Memorial Sloan Kettering, where a doctor called Barringer, who was a urologist, developed a way of treating prostate cancer by using long needles. And the top inch of the needle would contain some radon gas, which was called emanation gas, because it used to come off from radium, which was a very expensive radioactive isotope, which was really discovered by Marie Curie before that. But emanation gas or radon gas could be put into the end of a long needle. And what you do is you stick the needle into a tumor and hold it there for about 6 hours. Okay? They were tough men in those days. This was 1917. Okay? So I guess just after the First World War, this was nothing compared to what they'd been through in Europe. So they didn't mind having someone hold a needle in their prostate for 6 hours. But it would give off a big dose of radiation, and it would move it from one side then to the other side the following day. But it was a way of giving a big dose of radiation to the prostate with some good results. And shortly afterwards, some seeds were developed. So the idea came to maybe put some of this radon gas into seeds, encase it and put the seeds into the prostate, leave it there, so you don't have to be like holding something in the prostate for 6 hours. You just put the seeds in and leave them there. And that was used quite a lot in the late 1920s. Initially, you know, often there's a little bit of trial and error with all these things. Initially, what they did was they made the mistake of putting the radon gas or the emanation gas into glass beads. And for various reasons, glass isn't a great thing to use. So they ended up using gold and little tiny gold seeds that were radioactive back in the 1920s and implanting prostate. And I actually have a nice picture here that you can see of an X-ray taken in 1928 showing a prostate full of little radioactive seeds. But what do we do today? Well, we do similar types of treatment today. We use what's called temporary brachytherapy or high dose rate brachytherapy, where we get the patient into the operating room. He's put to sleep. When he's asleep, we put some needles in the prostate, hook these needles up to a little robot. And the robot will in a very programmed, controlled manner, send a radioactive pellet down each of the needles. So what it does, it moves down one needle and holds it there for maybe half a second. Moves it 2 millimeters further on for 2 seconds. Another couple of millimeters for 3 seconds. And by programming this little machine to send the radioactive source in and around the needles we have in the prostate in a certain predetermined manner, it will give a dose of radiation beautifully, precisely just where we want within the prostate. So that's called high dose rate brachytherapy. It usually takes about an hour and a half in the operating room to do the whole procedure, and the radioactive seed is in the prostate for about 10 minutes of that. Everything comes out, patient goes home, he's had his treatment. And that gives a big dose, a very big dose of radiation in a short period of time to the prostate. The other type of brachytherapy is where we leave the seeds in, a bit like what they were doing back in 1928. We put some, usually radioactive iodine, into little metal seeds and permanently place them in the prostate. They stay there, slowly giving off radiation over about 6 months. We use these different types of brachytherapy in different situations. The high dose rate brachytherapy is particularly effective at more rapidly growing cancers. So we usually use this combined with some external beam radiation to treat more rapidly growing cancers. And we've got very good results. The seed treatment, because the radiation is given off quite slowly, is usually used to treat more slowly growing cancers. And this is usually not combined with external beam, although sometimes it can be. So 2 types of brachytherapy, either high dose rate, which is a single outpatient treatment. Treatment is given over 10 minutes. Patient goes home, no radiation left in the body. The other type is permanent seed brachytherapy, where we place radioactive pellets in the prostate. They stay there, patient goes home, and as he's doing his business, he's coming to man-to-man meetings and all these sort of things, and PCCN network, the radiation is being delivered. So brachytherapy is used in 3 different situations. It's used on its own to treat lower risk prostate cancer, intermediate risk prostate cancer. So for example, a Gleason 7 cancer, where maybe you're not as concerned about cancer being outside the prostate, we can treat with permanent seed brachytherapy, where we leave the seeds in. And that works very well. The results from, for example, from British Columbia show that for Gleason 7 cancers, over 90% of men are cancer-free at 10 years after brachytherapy on its own, which is really good. It took us a long time in Ontario to get coverage by the Ministry of Health to allow us to do brachytherapy like this for men with Gleason 7 cancer. And up until about 3 years ago, we were constrained to just using this for Gleason 6 cancers. But with mounting evidence that it works just as well for Gleason 7 cancers, it has been funded. So for the last 3 years, we've been able to use seed brachytherapy throughout Ontario to treat men with Gleason 7 cancer. And in fact, that's the most common use we have now for permanent seed brachytherapy, treating Gleason 7 or intermediate risk prostate cancer. And we would expect that after seed brachytherapy, over 90% of men would be cancer-free long-term. The other way we use brachytherapy is to treat more aggressive cancers. So as we were saying earlier, when we're treating high-risk prostate cancer, we want to hit it hard in the prostate, because unless we kill the cancer in the prostate, we're lost. So we have to get rid of the cancer in the prostate. So rather than just relying on brachytherapy its own, because of the way the cancer can penetrate outside the prostate, we like to combine it with external beam. So we combine seed brachytherapy or high-dose rate brachytherapy with external beam to treat more aggressive cancers. So these would be the Gleason 8, 9, 10 that we mentioned earlier. The third place that we currently use brachytherapy is as what's called salvage treatment. So if someone has previously had external beam radiation treatment and the cancer comes back, like how many times have you said, oh, if you have surgery, then if it comes back, you can have radiation, yeah, which you have to do a lot. Or if you've got external radiation and the cancer comes back, you can't have surgery. Obviously, that is not quite true because some men can have surgery after previous external beam radiation, but there are other options, and brachytherapy is one that we use not uncommonly to treat patients who've got a recurrence in the prostate, again, after external beam radiation. So 3 indications for using brachytherapy. But back to the high-risk patients. The results of treating these men with radiation, standard radiation, remember we said at the very start of the talk is around 40% with radiation. So if we just use standard radiation on its own or standard surgery on its own, we're talking something in the 30 to 45% chance of that taking care of the problem. If we add in hormones, that's significantly improved. And now we have some good results showing that if we add in brachytherapy, results are further improved. So probably one of the most important and one of the most interesting studies that have been done in Canada in the last few years is a big randomized clinical trial of men with high-risk prostate cancer, where we ask the question, if we're treating men with external beam radiation as high a dose as we can, plus hormones, will they do better if we add in some brachytherapy as well? So this was a big clinical trial. It was developed initially by a Dr. Morris in BC Cancer Agency in Vancouver, but we took part in Sunnybrook as well. And we're grateful for all the patients who volunteered to take part in this clinical trial. So these are patients, men with high-risk prostate cancer. And as well as seeing if we could get better results with pushing the dose, we also wanted to limit the duration of the hormones. So instead of 3 years, we just used 1 year of hormones. So for men who had high-risk prostate cancer and treated with a high dose of external beam radiation, as high as we can get just if we use external beam on its own, and 1 year of hormones, the 8-year cancer-free survival rate was just over 60%. When we added in brachytherapy, so a year of hormones in total, external beam radiation for 5 weeks, plus a brachytherapy boost, the 8-year biochemical, or the 8-year recurrence-free survival, the chance of being without disease, was over 80%. So what it shows is that adding brachytherapy, intensifying the local treatment for men with high-risk disease, using brachytherapy compared to just treating with external beam on its own, halves the chance of cancer coming back, which is a really important finding. The paper, this is a study that has been presented for the first time in February of this year, and has been presented at many international meetings since. Papers have been written and are being submitted, and we hope that this will be in print very soon. But it's quite exciting, and what this has done is it has changed how we would approach men with high-risk disease. We long suspected that it made sense to use brachytherapy with external beam for these patients, rather than just relying on external beam on its own. But we didn't until recently have what's called level 1 evidence, which is what we get from doing a clinical trial like this, where men are randomized. Half have one treatment, the other half have the other treatment, and we see we see how they do. So we now have level 1 evidence that adding brachytherapy for men with high-risk prostate cancer will have the chance of the cancer coming back. And this has changed, as I said, a new standard for how we treat these men. So how are we going to improve results for these men? Well, we mentioned two things. We said intensifying local treatment, and that seems to work. It seems as if using a higher dose of radiation, which we can only do with brachytherapy for these men with high-risk disease, halves the chance of cancer coming back compared to the best we can do with external beam treatment. And at the same time, in this trial, we limited the amount of external beam, so it could, of hormone treatment. So it could be that when we push the dose locally, when we give a very high intensive treatment with brachytherapy and external beam, we don't need to give 3 years of hormones. Maybe 1 year is going to be sufficient. The other way we said we can improve results, or we might be able to improve results, is by adding in chemotherapy to the mix. Because men with high-risk disease, the Gleason 9, the Gleason 10, men who've got a PSA of 100 at diagnosis, and I see these men all the time. Even though we get rid of all the cancer in the prostate with brachytherapy and external beam, they're still at very high risk of harboring microscopic seeds of cancer in other parts of the body that no imaging test, no X-ray or scan has been able to pick up. And we know that if we just treat the prostate alone and the pelvis alone, they're still at high risk of getting cancer spread somewhere else in the body, often in bone. In other cancer sites, in rectum, in breast, in lung, it is well known that chemotherapy early on improves survival. So for example, when we treat women with breast cancer, we just don't treat the lump in the breast. After local treatment, most women with breast cancer, especially those who are younger, would receive chemotherapy because there is a wealth of information, many clinical trials that show that for women with breast cancer, adding chemotherapy early on improves survival. And that's why a lot of women with breast cancer end up having chemotherapy, because when you look at results 10 years later, early chemotherapy will increase the chance and maximize the chance of the woman surviving and being well and healthy 10 years later on. How about prostate cancer? Well, in the last year, there have been 3 studies that have looked at this question. They've asked, for men with high-risk disease, should we add in chemotherapy early on? Is it a benefit? Up until now, chemotherapy for prostate cancer has been reserved for the end. You know, you say to men, okay, if the cancer comes back, what we'll do is we'll give you hormones first of all, and whenever the hormones stop working, which may be 2 or 3 years, we will then use chemotherapy or some other agent. But is that the right thing to do? It's not what we've been doing for breast cancer. For breast cancer, we started doing that because when we were treating women 30 years ago with breast cancer where the cancer had spread, we found that chemotherapy worked, and people asked, well, should we wait for it to spread before we give chemotherapy? Maybe we could hit it off with a pass and prevent it spreading by using chemotherapy earlier on. So we have a number of clinical trials, 3 clinical trials, that have asked the same question recently for prostate cancer. The main chemotherapy drug used in prostate cancer is a drug called docetaxel. Or Taxotere. It's a derivative of a Pacific yew tree. So it comes from the bark of a tree. So just like, you know, many treatments we use, they're founded in nature, and they've got some natural derivatives. So docetaxel from the yew tree was shown about 10 years ago to improve the survival of men who had cancer that had spread and was no longer sensitive to hormones. But people said, oh, chemotherapy. Well, there's a few things about chemotherapy. People get really sick with chemotherapy. It's too nasty. We shouldn't use it early on because of all the side effects. It's very expensive. So there are many reasons prostate cancer patients, often they're old men, they won't tolerate the chemotherapy very well. So there are many, reasonable arguments for not looking at chemotherapy early on. So what the studies have shown is, well, we were wrong. We were wrong. In fact, it looks as if early chemotherapy seems to be a good thing. So the first study to look at this was looking at men where the cancer had spread. So the cancer had spread, and normally what we do is we keep the chemotherapy in reserve. We keep docetaxel or taxotere in reserve and use it until the hormones stopped working. So a very influential clinical trial, and again, this was just published last year, just reported last year for the first time. It's called the CHARTED, C-H-A-R-T-E-D, the CHARTED clinical trial. Randomized men who had metastatic prostate cancer to hormones alone and chemotherapy later on, which was kind of the standard way of treating men, or hormone treatment, but chemotherapy up front, just as we would treat breast cancer. And the chemotherapy up front improved survival. Men lived longer and had a much higher chance of being alive and well 5 years later on if they had chemotherapy at the start when we started treating them with metastatic disease, rather than waiting for the cancer to become hormone insensitive, or to use the current term, castration resistant. So that's what cancer that had spread. But how about before it has spread? There have been 2 clinical trials that looked at this question. One took men with high-risk prostate cancer and randomized them to radiation and hormone treatment, which was our standard, remember, or radiation and hormone treatment with chemotherapy. Okay? So this is a test of whether or not giving chemotherapy up front for men with high-risk disease is of benefit. The results, the preliminary results, were just announced 2 months ago at a major meeting. And what the first look shows is that, yes, there is an improvement in survival. Looking at men's survival at 4 years, there was a statistical increased chance of being alive if men with high-risk disease had chemotherapy at the start. There's a cost. There was greater side effects associated with it. And these are preliminary, and longer follow-up is going to be needed to have this as a definitive study that's going to change practice. And there is a second, that particular clinical trial was a European study. There was also a study from the North American group. It's called the RTOG, the Radiation Therapy Oncology Group, that conducted a very similar study with very similar results. So there are 2 studies, one European, one North American, which at the first look both show that intensifying the systemic treatment by adding in chemotherapy seems to be a good idea for men with high-risk prostate cancer as well. Now, the evidence isn't such that we can now say, yes, for men with high-risk localized disease, we've got to give them all chemotherapy. But it may well get there within the next year. There's certainly a strong suggestion from these clinical trials that we should be doing chemotherapy earlier for these men. It has changed how we manage men with metastatic disease. And young men who've got cancer that has already spread, we tend to treat with hormones and chemotherapy at the start. And again, this is a change in practice in the last six months or so. So where are we going with high-risk prostate cancer? Well, we have established that one treatment alone isn't good enough for men with high-risk disease. Surgery alone, abysmal results, 33%. 3-year disease-free survival in one of the best surgical centers in the country. So that's not good on its own. Radiation on its own, not so good either. The biggest study shows that maybe about 40% of men are cancer-free after radiation on its own. Radiation and hormones, now we've improved. Now we've improved survival significantly. We've halved the chance of dying of prostate cancer when we add in hormone treatment initially. What's the next step? Well, intensifying local treatment. Instead of just relying on the external beam part of the treatment, add in brachytherapy as well. So that we can eradicate the cancer in the prostate. And again, that will have, once again, the chance of cancer coming back for men with high-risk disease. How about managing the side effects? Well, let's limit the duration of hormones. Instead of 3 years, maybe make it 1 year might be adequate. And where the biggest interest is at the moment is saying, well, how about chemotherapy early on? Should we do that? We know it works really well for men who've got advanced cancer. It improves survival after the hormones have stopped working. There's good evidence now that it's probably better to use it before the hormone stops working because we get a much better result then. And the next step would be to wait for the studies that have brought this into the very early treating cancer that hasn't yet spread. And we need some more definitive evidence that also improves survival. So adding chemotherapy earlier. And also newer agents. There are many, many new agents out there. And at the start, when a new treatment comes available for prostate cancer, we use it to treat men at the end stage. So the first group of men that have treatment with new chemotherapy drug X or new hormone drug Y are men who have already had all the available options. They've already had chemotherapy and hormones. So the chance of them actually responding to a new treatment is relatively small. But yet there are a number of new treatments out there that have been shown to improve survival. There are new drugs that many of you may be on or have heard of, enzalutamide, abiraterone. A new very interesting agent is what's called radium-223, which is radioactive radium, just like what we mentioned way back in 1909 that we were using to treat prostate cancer that was still in the prostate, but using a different radioisotope of radium that gives off what's called alpha radiation. Now, this is a really interesting compound. It's radium, but the radiation, the X-rays, travel a fraction of a millimeter. Okay, so they can be blocked by a sheet of paper. So they're not very penetrating radiation. You say, well, why would you use something like that? And the reason is that radium, if you give it by injection, goes to the bones and goes to areas of the bones where there is increased bone turnover. Many of you have had bone scans. And in a bone scan, what happens is the man is given an injection of a radioactive tracer that goes around the body, is taken up in the skeleton, and goes selectively to areas where there's cancer. So instead of just using something that's going to show us where the cancer is, could we also use something that, as well as going there, will actually deliver a radioactive dose, a dose of radiation? And radium is able to do that because it goes to areas of increased bone turnover, areas of cancerous bone in the body after a single injection, travels, sits there, and gives off radiation with a very short range. And there has been a big clinical trial initially called the Alsimka study that showed an improved survival for men who had really reached the end of the road in terms of treatment. So it improved survival. So it actually worked. But there are a lot of studies now looking at, can we use this earlier on in the course of disease? Do we have to wait for the cancer to spread? Can we give it, because the biggest problem that men with high-risk prostate cancer develop is spread to bone. Can we prevent this or hit it off at the pass by using something like radium, as well as some of the chemotherapy drugs, to help target prostate cancer, microscopic metastasis, before it becomes a clinical problem? So there are many new questions being asked, particularly around new agents, to see if we can actually improve results and minimize the chance of cancer spread elsewhere. How are we doing on time? 8:30. So I think my time is probably up. I apologize for the fact that my slides aren't great. Now, there's obviously a number of reasons for that. I'm going to blame the projector. Could be the computer. It may also be to the fact that in the introduction that you heard at the start, talked about my desire to escape to the wilderness. Let me just leave you with a story. This is a true story, something that happened last night. I thought you might find it of interest. I was in a tent last night with my wife on an island in Georgian Bay, and heard a noise, and of course it was a bear. Now we'd previously seen the bear. He came to work. It was just the two of us on the island. The bear had come around earlier that day. I chased him away, but obviously he came back again, and he was, for some reason, he seemed to really like my wife's deodorant, which he had in the kayak. So we kayaked to the island. This bear is a bear who really likes deodorant. Probably he's got some personal hygiene issues. But anyway, we got him. He was after my wife's deodorant, opening the hatch in the kayak, so I chased him away. But he came back again. Second time I chased him away. He was a little bit slower to run away the second time. I think he'd gotten the taste for the deodorant. And I think he was probably really trying to decide, well, which of us is the bigger, okay? And I'm glad he wasn't that bright, because he didn't really put two and two together. But at that point, my wife said, you know what? We're not going to wait for him to come back a third time. So midnight last night, we set off in our kayaks. We had a beautiful moonlit paddle into Dillon by the moon. It was gorgeous. Not the ground, the water was like a mirror. It was like glass. So I didn't get home until 5 o'clock this morning after being chased. I'd have probably stayed, but my wife really took offense to her deodorant being eaten by the bear. But I think it's just a reminder, you know, we've got a fantastic world out there. Canada's a great country. And I guess my wish for you and for people here is that you're going to be able to enjoy the great world we have around us. So thank you very much for your attention.